So good day, and in today's video we are going to discuss about the pubis or the pubic bone or the os pubis. This bone is ventral to the ilium and the ischium, and it consists of a body which is quadrilateral in outline and two rami, a superior ramus and an inferior ramus, which joins with the ramus of the ischium to form the ischiopubic ramus. Now, this body, it is having three surfaces. One is the outer surface or the anterior surface. This is the anterior surface, and the direction of the anterior surface is downwards, forwards and lateral. Okay, and the inner surface, which looks upwards, backwards and medially, it is the pelvic surface. And this surface is the symphysial surface which forms the symphysis pubis, and it is directed downwards, forwards and medially. Okay. Now the symphysial surface is covered by hyaline cartilage, and with the similar surface of the opposite side, it forms the symphysis pubis. Between the two hyaline cartilages is a fibrocartilage present, forming a secondary cartilaginous joint. Now, this anterior surface, this is the anterior surface, and this body, it has two borders. One is the superior border, which forms the pubic crest, and a lateral border, which is formed by the anterior boundary of the obturator foramen. Okay. Now, at this anterior border, at the junction of the symphysial surface and the superior border or the pubic crest, here there is a rounded origin of the tendon of the adductor longus. So here you have the origin of the adductor longus, and then from the outer surface there is origin of the gracilis and adductor brevis. These origins extend to the ischiopubic ramus. From the body, it extends to the ischiopubic ramus. The origins of the gracilis and the adductor brevis extends from the body to the outer surface of the ischiopubic ramus. And in this part of the body, adjacent to the margin of the obturator foramen, there is the origin of the obturator externus. So, from the anterior surface, you have origins of adductor longus, gracilis, adductor brevis, and of the obturator externus. Now, coming to the pelvic surface, this surface is separated from the anterolateral surface of the urinary bladder. Okay, and in this retropubic space, there is presence of fibrofatty tissue and venous plexus. Okay. In this surface, along the adjacent margin of the obturator foramen, here you have the origin of the obturator internus muscle, and from the middle of the pelvic surface, you are having the origin of the anterior fibers of the levator anines. Okay. Now, coming to the superior ramus. The superior ramus, it extends from the upper part of the quadrilateral body, and it is directed backwards, upwards and laterally. And at the iliopubic eminence, here is the iliopubic eminence, it fuses with the ilium. The iliopubic eminence gives attachment or origin to the psoas minor muscle, which is an occasional muscle. It may be or may not be present. The superior ramus, it has 3 borders and 3 surfaces. The 3 borders are the anterior border, the posterior border, which is also called the pectineal line or the pecten pubis, and an inferior border. This is the inferior border of the superior ramus. This part, it continues as the lateral border of the body, along with the being continuous with the margin of the obturator foramen. Now this anterior border, it extends from the inferior aspect of the acetabular cavity, and it extends up to the pubic tubercle. Pubic tubercle is a rounded bony projection from the lateral aspect of the pubic crest. So this is the pubic crest, and here you have the pubic tubercle, and here is the obturator crest. And the pectineal line from the iliopubic eminence, it is the continuation of the arcuate line, and it extends up to the pubic tubercle. The obturator crest that you can see here, at the lateral part, it gives attachment to the pubofemoral ligament. It gives attachment to the pubofemoral ligament. Okay, and this crest, it overhangs the obturator surface. Now, between the obturator crest and the pectineal line, this surface is known as the pectineal surface. To the inferior border, you have the attachment of the obturator membrane, which is continuous with the lateral border of the body of the pubis, and here you have the attachment of the obturator membrane. But here at the upper part of the obturator foramen, there is a gap where the obturator membrane is not attached. So here from the medial and lateral aspect of the margin of the obturator foramen, there are 2 tubercles, okay, and in this part the obturator membrane is not attached, so there is a gap forming the obturator canal for the passage of the obturator nerve, obturator artery, and the obturator vein from above downwards. Okay, so these structures pass through the obturator canal like this, and the obturator membrane that you can see, which I am representing by my fingers, it has a gap in the upper part, which is known as the obturator canal, through which the obturator nerves and vessels pass. Now we shall discuss about the attachment of some important areas. First of all, let's start with the superior border of the body. Okay, these structures that we are discussing are mainly important for your abdomen part, but since we are studying the hip bone for the inferior extremity osteology portion, we shall just mention the names of those structures so that when you study the abdomen part, it becomes easier for you to follow. So first of all, let's talk about the pubic crest. The pubic crest, or the superior border of the body of the pubis, it gives attachment to the following structures from before backwards. First you have the attachment of the fascia lata, which is the deep fascia of the thigh. Okay. Then you have the attachment of the anterior layer of the rectus shield. Behind that you have the attachment of the lateral head of the rectus femoris with pyramidalis muscle in front of it when present. Behind that you have the attachment of the conjoint tendon, and most posteriorly you have the attachment of the fascia transversalis. Okay. So these are the attachments of the pubic crest. Now the pubic tubercle, which is the bony projection from the lateral aspect of the pubic crest, it gives attachment to the medial end of the inguinal ligament, and it also gives attachment to the lacunar ligament. The apex of the lacunar ligament is attached here. Then it gives attachment to the reflected part of the inguinal ligament. Then it also gives attachment to the lateral truss of the superficial inguinal ring. It gives attachment to the lateral truss of the superficial inguinal ring and also to the superior truss of the saphenous opening. Now in this regard, it must be mentioned that the inguinal hernias come out through the superficial inguinal ring and the femoral hernia come out through the saphenous opening. So the lateral truss of the superficial inguinal ring and the superior truss of the saphenous opening are attached to the pubic tubercle. Okay, and it also gives attachment to the U-shaped ascending fibers of the cremastric muscle. So these are the attachments of the pubic tubercle. The most two important structures attached here are the inguinal ligament and the apex of the lacunar ligament. Okay, and if you want to remember more, then you should remember about the lateral truss of the superficial inguinal ring and the superior truss of the saphenous opening. Now coming to the pectineal line. The pectineal line, the medial part, it gives attachment to the lacunar ligament, to the reflected part of the inguinal ligament. It gives attachment to the conjoint tendon of the transversus abdominis and the internal oblique muscle, and to the fascia transversalis. The lateral part gives attachment to the pectineal ligament of Cooper and the pectineus muscle and its fascia. This pectineal surface between the obturator crest and the pectineal line, it gives attachment to the pectineus muscle and its covering fascia, which is covered by the pectineal fascia. Now, about this pelvic surface, this surface is covered by peritoneum and it is crossed by the obliterated umbilical artery and posterolaterally by the round ligament of the uterus or the vas deferens. Now about the ischiopubic ramus, which is formed by the inferior ramus of the pubis and the ramus of the ischium. We have already discussed their attachments and borders and surfaces. Okay. So we are not discussing about the inferior ramus of the pubis as we had already discussed it. Now, we have to talk a bit about the acetabulum. We have discussed that in the middle of the hip bone there is a constriction, and at its outer aspect there is a deep cavity which forms the acetabular cavity or the acetabulum. Now, the margin of the acetabular cavity is deficient at its inferior aspect, and here it is bridged by a ligament which is known as the transverse acetabular ligament. Okay, and to the transverse acetabular ligament and the margins of this notch, this is known as the acetabular notch, there is attachment of the base of a triangular ligament, the ligamentum teres femoris. The apex of this triangular ligamentum teres femoris is attached to the pit or fovea in the head of the femur, which you will know when you study the femur. Okay, so this is the transverse acetabular ligament, and from here you have the attachment of the base of the triangular ligamentum teres femoris. Now, in the acetabular cavity you have a semilunar articular area which is known as the lunate surface. Okay, this is the lunate surface, and in the floor there is a depression which is occupied by acetabular fat which is liquid in body temperature. Now, this acetabular fat is covered by synovial membrane, so it is intracapsular but extrasynovial. And about the triradiate cartilage we have already discussed several times previously. Now, to the margin of this acetabular cavity you have the attachment of a thin slip of fibrocartilage which is known as the glenoidal labrum. This glenoidal labrum is triangular on cross section. Okay, and it is attached around the margin of the acetabular cavity, and the transverse acetabular ligament is believed to be derived from the acetabular labrum itself. Now, the capsular ligament of the hip joint is attached to the margin of the acetabular, beyond the margin of the acetabular cavity and the attachment of the acetabular labrum. So, acetabular labrum is intracapsular. Okay. Now, we shall discuss about a very important topic, that is the anatomical position. So, when you get the hip bone in your examination table, first you must determine the side and hold the bone in anatomical position. For this, the knowledge of the bony parts was very essential. So we had discussed about the bone as a whole. Now we are coming to the anatomical position. So when you hold the bone in anatomical position, you must keep in mind that the anterior superior iliac spine and the upper margin of the symphysis pubis must be in the same coronal plane. So these two structures are in the same coronal plane. Okay. The direction of the symphysial surface is downwards, forwards and medially. The direction of the acetabular cavity must be downwards, forwards and lateral. Okay. The ischial tuberosity forms the lowermost aspect of the bone, and if you draw a line from the tubercle of the iliac crest, to the lowermost part of the ischial tuberosity. So from ear to ear, if you draw a vertical line, then it will pass through the center of the acetibular cavity. Okay. So you must keep these points in mind when you hold the bone in anatomical position. And in sitting position, however, the anterior superior iliac spine, the center of the acetibular cavity, and the lowermost part of the ischial tuberosity, they are in a same line. Okay. So this is about the anatomical position. The anterior superior iliac spine and the upper margin of the symphysis pubis are in the same coronal plane. The symphysial surface is directed downwards, forwards and medially. The acetibular cavity is directed downwards, forwards and laterally. And the tubercle of the iliac crest, the center of the acetabulum, and the lowermost part of the ischial tuberosity are in the same line. Now about the ossification. There are three primary centers of ossification, one for each ilium, ischium and pubis. The ilium develops from a primary center of ossification which appears in the second month of intrauterine life. The ischium, the body of the ischium appears from a primary center of ossification which appears around the fourth month of intrauterine life, and the body of the pubis ossifies from a primary center of ossification which appears at the between fourth and fifth month of intrauterine life. Now the remaining bone, it is cartilaginous at birth. The ischiopubic ramus is ossified from cartilage around the age of 7 to 8 years. And around the age of puberty, there are certain secondary centers of ossification appearing. There are secondary centers of ossification for the iliac crest, for this triradiate cartilage, for the ischial tuberosity, for the anterior inferior iliac spine, and for the symphysial surface. For the iliac crest and the triradiate cartilage, there are two secondary centers of ossification. So, the secondary centers of ossification appear around the age of puberty for the two for the iliac crest, two for the triradiate cartilage, one for the ischial tuberosity, one for the anterior inferior iliac spine, and one for the symphysial surface. Now, between the age of 15 to 25, the entire hip bone is ossified. So, all the cartilages are replaced by bone between this age group, between 15 to 25 years. So, one last note, the ilium is considered to be the dorsal component of the hip bone, and the pubis and the ischium are considered to be as a ventral component of the hip bone. This is because the muscles that are attached to the ilium are supplied by the dorsal division of the lumbar plexus, and the muscles that are attached to the pubis and the ischium are supplied by the ventral division of the lumbar plexus. So, I hope these videos will be helpful. Please take the help of your bone sets and pictures in the atlas. That will be helpful to understand the video. So, thank you.